Appreciate you guys joining today for our webinar on the CMS interoperability rule, and more specifically, the new event notification requirement of that new rule. Before we get started, just a couple housekeeping things. We have placed all the lines on mute. Would appreciate you all kind of staying muted during the presentation, but we certainly want to hear from you, answer any questions that you might have. During the presentation, if you have questions, if you'll type those in the chat, you can send them directly to me, and I will prompt the presenters with those questions as it makes sense, or we'll save those until the end where we have kind of some time set aside for a QA section. So little quick background, as many of you know, back in 2017, THA launched a new admission, discharge, and transfer data program that we call ConnecTN. We did so in response to what at the time was an optional, and it was really just a request from TennCare, but has since become a requirement that hospitals provide this data, and they were interested in that data to support their patient-centered medical home and HealthLink initiatives. So we've been meeting that requirement since 2017 for hospitals that are connected to our data program. As of today, we have 120 acute care hospitals and psychiatric hospitals connected to the system, and they're sending in real-time, all-payer ADT data for inpatient and emergency department settings of care. We've done all this with our great partners at Audacious Inquiry. Just a little bit of background on AI. They're national leaders in encounter notifications and event-driven clinical data exchange. They demonstrate that every month by typically sending over 6 million event notifications across the country with the networks that they run and operate. And as we'll demonstrate today, AI has both a level of expertise in policy with their work with ONC and CMS, but also the ability to shape their technical solutions in a rapid, secure, and scalable way, which is what we're doing today with ConnecTN. What started out as a voluntary extension of THA's existing data programs has, with ConnecTN, has become a tool that can satisfy both that TennCare requirement that hospitals be providing this data, but also these new CMS regulations. And so looking at the agenda for today's meeting, in a moment, we'll introduce the team from AI. They will dig in and provide some detailed information on this new regulation and the requirements. They'll provide a more in-depth background on ConnecTN and how it can be used to comply with these new requirements. And lastly, we'll summarize and talk through next steps for your hospitals and answer any questions that you might have. So with that as the background on how we've gotten to this point, I'm going to turn it over to David Rodriguez. David is the Senior Director with Audacious Inquiry, and he'll introduce the rest of his team. David, I've had the pleasure of working with David since 2017. He has been integral in getting ConnecTN to the place that it is today. But he also works with the Georgia Hospital Association and the network that they're running as well. So he knows this landscape really well. So David, I'll turn it over to you.
Thanks, Brian. Hey, everybody. Our team is very excited to talk with you all today. As Brian mentioned, I lead our work in Tennessee with Tennessee Hospital Association, with the Georgia Hospital Association, and in Louisiana with the Louisiana Hospital Association. And you'll hear from two speakers on the AI side today. Corey Mertz first. He's our Senior Policy Director at AI and is a subject matter expert in federal health policy and interoperability, and works with clients all the time translating really complex and lengthy rule texts and federal regulations like the CoP into actionable strategies for our customers across the country. Dr. Samit Desai is our Chief Medical Officer at AI, and he offers his clinical perspective in support of our value-added product enhancements and serves as a senior advisor to our customers across the U.S. and is also a practicing ER physician at Assertion St. Agnes in Baltimore, Maryland, and is double boarded in emergency medicine and clinical informatics. So with that, I will turn it over to Corey to walk through aspects of the rule.
Great, thanks, David, and good morning, everybody. So as was mentioned, right, earlier this year, CMS finalized a new condition of participation in the Medicare and Medicaid programs requiring hospitals, psychiatric hospitals, and critical access hospitals to send electronic notifications to certain community providers that have an established relationship with a patient seen at your hospital. Really important caveat, this condition of participation only applies to these facilities that have either an electronic health record or an electronic administrative system, so think billing, registration, that uses HL7 2.5.1. So if a hospital that otherwise would kind of fall under this doesn't have that type of system, they wouldn't. I would say, most hospitals that we've seen across the country certainly have that either through an electronic health record or through their kind of administrative or billing system. But just an important caveat for any hospitals where that is not the case. As far as the timing of this requirement, it goes into effect in May of 2021. So, I think one of the really important things, and we'll kind of hit on this throughout my part of the conversation at least, and some other places as well, as this is going to be a new part of the conditions of participation, it's going to be important to add compliance into your existing compliance program, right? So making sure your policies and procedures address this and you're ready when the surveyors come on site, that you can demonstrate how you're complying with this new electronic notification requirement. So we'll talk about that in a little more detail, but let's jump to the next slide. So as you think about what's required here, right? So CMS outlines that hospitals have to make a reasonable effort to send notifications in the kind of following instances, right? And they outline a couple event types in particular. So when a patient has an inpatient emergency department or observation, admission, discharge, or transfer, you have to generate a notification in those instances. The kind of one caveat here is once there is an inpatient admission, if they're kind of being transferred within that admission, to a different floor or different setting, you do not have to do it for transfers within an inpatient admission. So just want to note that. And who do the notifications have to go to? So CMS outlines three categories. The first is the patient's established primary care provider or primary care practice. The second is the patient's established post-acute care provider and suppliers. So a good example here would be, right, if the patient is admitted from a skilled nursing facility, CMS's expectation would then be that you provide notifications back to that skilled nursing facility about the patient. And the third category, which was net new in the final rule, was the ability for patients to assert a provider that's primarily responsible for his or her care that they want notifications to go to. And this is really left quite open-ended, right? It's not just a primary care provider or a post-acute care provider, right? A patient could say, hey, a specialist like a cardiologist is the provider who typically gives me my care, and request that the hospital provide a notification to that provider, and then the hospital would have to make a reasonable effort to figure out how to route a notification to that provider as requested by the patient. As you think about the reasons notifications have to be generated, is for treatment, care coordination, and quality improvement purposes under the kind of conditions of notification requirement. Certainly a lot of other federal requirements coming out right now around, when and where providers and others have to share data. So as you think about the kind of your obligations as a hospital under the new information blocking rules from ONC and HHS, certainly broader obligations there. But as you think about complying with the condition of participation requirements, it is just for the treatment, care coordination, and quality improvement purposes. So just an important thing to keep in mind as you're thinking about complying both with this requirement and kind of other requirements that are coming down from the federal pike. As you think about who this covers, it's important to keep in mind this is all patients. Any patient that's going to hit these triggering conditions, notifications would have to go out for. It's not just Medicare and Medicaid patients, it's all patients. And as you kind of think about the data that has to be shared, it's a pretty minimal data set that CMS requires for compliance with the condition of participation. So you have to include the name of the patient, the name of the treating provider, and the name of the sending institution. And as far as the kind of content and transport standards, they really leave it open-ended as far as how, you know, what the formats are and how you do that. The CMS kind of purposely leaves that quite open-ended to allow hospitals and the kind of receiving providers to work out what makes the most sense in their particular environment. A couple other really important things to keep in mind. In the rule, CMS is very clear that hospitals can rely on intermediaries like ConnecTN to support their compliance with this rule, right? So a hospital can send their ADTs to an organization like ConnecTN to then distribute to the appropriate providers on their behalf. And CMS also in the rule talks about kind of subscription-based models like how ConnecTN works, where, you know, a community provider comes and says, these are the patients I'm interested in getting alerts on. And that's how kind of notifications are then generated. So, you know, CMS recognizes that's happening out in the field and very clearly in the rule kind of says that, you know, those types of models are in line with how we want this to work and how we've kind of structured these requirements. The one other thing that I think is really important to keep in mind, CMS does also clearly outline in the rule that, you know, if there are, you know, if a patient expresses a privacy preference, for instance, for their data not to be shared, or if there is, you know, for instance, if it's part, you know, 42 CFR Part 2 data where, you know, explicit opt-in consent is required prior to the data being shared. If those preconditions haven't been met, or again, if the patient under HIPAA has kind of expressed a preference to not have their data shared, it's okay that you don't share the data, right? There are other conditions dictating that. There are existing privacy rules, you know, that kind of trump the notification requirement here. So just keep in mind from a compliance perspective, you're going to be okay, and CMS explicitly kind of talks about that and recognizes those types of scenarios will exist here. So let's go to the next slide. So the kind of last thing I want to talk through is how this is likely going to get enforced, right? So again, this is going to be through the survey and certification process. CMS has bundled this condition of participation under the kind of general medical records bucket across these groups. So as you think about how it's going to be enforced, we certainly are anticipating it's going to follow similar processes that CMS uses for other conditions of participation under those categories, right? So they'll look at organizational structure, policies and procedures that you have in place, you know, that demonstrate how you're implementing these things. They'll certainly look at, you know, sample medical records of patients that are there during the survey, really to see, hey, did a notification get generated when it should have in these kind of conditions and to meet the requirements. So those are some of the things we're anticipating we'll see them go down. CMS is also committed to, prior to the enforcement of this condition of participation starting next year, that they will provide updated guidance to surveyors. That has not come out yet, but we're certainly watching for that and waiting to see the contents of that requirement. So with that, I will pause and see if there are any questions that have come in on the chat, and if not, I will turn it over to David to keep running forward.
So I did have a couple of questions.
Yeah.
The first I've addressed via the chat. Yes, we are going to be providing a copy of the slides and a recording of the webinar to all registrants, so you guys will all get that. The other question I have is, or that I received is, are long-term acute care hospitals required to meet this same, required to provide these same types of notifications?
That's a good question. I remember I looked into this. I think, you know, the rule, let me double check that. I'm pretty sure it's no. But I'll double check it as we go through the rest of the presentation and circle back if I got that wrong, but 99% that it's a no.
All right, thanks for it. Okay, there's another question here. They ask, I am assuming notification will be sent back to the hospital in an ADT. It looks like an AO8, is that correct? Not sure.
That might be more aligned with the kind of next part of the presentation.
Okay.
Maybe we can tackle it there.
Okay. That sounds good. Those are all the questions I have.
Okay. All right. Well, I'll turn it over to David then.
All right. Thanks, Corey. So this slide indicates kind of the value of an intermediary, which you just heard Corey touch on briefly. And kind of as he mentioned, after considering all of the public comments, CMS actually called out intermediaries specifically in the regulation text because they recognize the extensive challenges and burden this rule often places on hospitals to kind of manage all of these outside connections. And as an intermediary, ConnecTN can uniquely solve this problem of ensuring important stakeholders in the community receive necessary information and alerts. So the left-hand side represents the complexity of hospitals taking this on internally, managing individual connections to notify outside providers. And while many hospitals may have the inherent ability to do this within their own integrated delivery networks, many hospitals don't have established ways to notify outside PCPs, SNFs, rehab facilities, or any other providers identified by the patient. And on the right-hand side, that represents ConnecTN essentially doing all of the hard work for you, distilling this into a single and simple process where you send us as a hospital a single ADT feed that's compliant with specifications. And it's our job to do the hard work of determining where and when notifications need to go. So we are essentially doing this because we have this capability. This is an established program that's been in place for 3+ years, and we want to meet this requirement for you. So now that we've kind of broken down the policy aspects of the rule from Corey, I thought it would be important to provide kind of an overview of what ConnecTN is before we demonstrate how it actually complies with the COP. And some of you may be familiar with this program, some of you may be hearing about it for the first time, so we're going to balance some background information here. So ConnecTN is powered by AI's Encounter Notification Service that operates around the country in 13 states and the District of Columbia. And we receive data in real time from participating hospitals and have the ability to notify a subscribing organization or provider when their patients have encounters at any of our connected facilities. And those encounters are inpatient or emergency department events today, and as the rule states, we'll also be including observation status as well. These patients are provided via a member roster or a panel, and these notifications are used for the purposes of care coordination activities and post-discharge follow-up care. So kind of breaking that down further into a visual diagram, we have our data sources on the left, which again represent 120 connected acute care and psychiatric hospitals in the state of Tennessee today. And on the right, we have our subscribing organizations of hospitals, TennCare, physician practices, ACOs, and health plans. And these organizations provide a list of their patients they'd like to receive notifications about in step 2. And in the middle, ConnecTN is a fully cloud-hosted solution in a high-trust certified environment, leverages a master patient index to compare the 2 sources of data that come in step 1 from the ADT feed and in step 2 from the member roster. And when a match occurs, we generate an alert and send out to the appropriate subscriber in the form of a notification in step 4 through a delivery method of choice with additional considerations for filtering or any rules-based logic that we'll touch on shortly. So ConnecTN, by the numbers, some of these we've covered already. Our 120 hospitals represent 80% of the bed coverage in the state, and we have 4.6 million subscribed patients that, again, represent the amount of patients that are on panels across all of our subscribing organizations today. And we are currently generating or delivering over 1 million notifications a month to a variety of different organization types. So notification delivery, across the country, many of these providers are going to be, as a result of this rule, are going to be receiving notifications via direct secure message. And our experience, we know that workflow and preferences matter. And there's really no single way, as many of you know, in which providers would like to receive notifications across the board. So we kind of take this Swiss Army knife approach to account for these variations to deliver alerts in the most meaningful way. And for some, that may represent receiving alerts in a simple method like the use of our web portal or a daily CSV file that's in the form of a spreadsheet. But for others, there may be more sophisticated or complex integrations that leverage or require HL7, FHIR, the use of APIs, or a wide array of other methods to seamlessly integrate directly into the provider's workflow. And ultimately, the key takeaway here is that we're sensitive and mindful of the fact that for much of the country, the direct method is going to be widely adopted, but we understand that routing notifications through preferred methods is critical to have a meaningful impact for providers, but also minimize the massive amount of noise that may result from this rule. So I'm going to pause here before we kind of transition into how exactly this solution meets the COP requirements, and we'll offer to take any questions. We'll let you guys kind of catch up and submit some through the chat. So Brian, have we received any?
Well, while we're checking, I was actually able to find the answer to the LTAC question, and I was wrong. They are covered. So LTACs are included in the hospital definition. Yeah, sorry about that.
Yeah, Corey, on that same vein, there was a question about inpatient rehab and subacute hospitals as well.
Yeah. Let me pull my notes up. They inpatient rehab. Yeah, rehabilitation hospitals are covered. Yes. And what was the other one?
Subacute.
Subacute.
I have to dig into that more. I'm not sure. My guess is yes. Oh, we're talking like short-term acute.
Yeah, he clarified SNFs, so skilled nursing facilities.
Oh, skilled nursing facilities? No, they're not.
Okay.
Right. I think we can loop back to one of the questions earlier. There was a follow-up. So I'm assuming notification will be sent back to the hospital in the ADT 808 format, and will it be possible for AI to send the hospital MRN back? So yes, when we generate a notification, and there will be a visual here in one of the upcoming slides that kind of talks about the concept of a subscribing organization that receives alerts, and then kind of a non-subscribing organization where we capture the information provided by the hospital and then route the notification accordingly to the downstream provider. But yes, we can include the hospital MRN in that outbound notification. And then the ADT question, we can send, I kind of alluded to the different subscriber preferences or alert preferences. We can trickle that down to specific event types. So Corey talked about there's a key set of event types that are required in the form of a notification, but we can work with downstream providers or subscribers to customize the types of events they want to receive. And although I would not advise folks subscribing to 808s, we can certainly do that.
Okay. I have one more question here. Hospitals are required to send notifications out to various recipients, e.g. home health providers, inpatient rehab, DME providers, imaging center, physician practice, etc. But are those recipients required to have technology and systems in place that allow them to send notifications and patient information back to the hospital under this rule?
Corey, do you want to take
Corey,
that
do you
one?
want to take that one?
Yeah, sure. So I think the gist of the question is, is there a kind of similar requirement on the receiving organization from CMS?
Mhm.
Is that, yeah,
Yep.
okay. There is not, right? So this condition of participation is just on the hospital side. There is no, CMS has not adopted a similar requirement for primary care providers or skilled nursing facilities or others to kind of receive and do anything with the notifications per se. Again, I think this is important, or this is where it's important to keep in mind the reasonable effort part, right? And CMS put that into the regulation to kind of set a bar for hospitals. They're a little unclear on what that bar is, but it's not like the intent isn't that the hospital has to do everything possible under the sun to get a notification to a provider. You just have to make a reasonable effort.
Okay. What is the turnaround time for this information being sent to the next provider?
So it's supposed to be at the time of admission, either before or at the time of discharge.
So essentially immediately as the patient's admitted and as the patient is discharged.
They give you a little wiggle room, but yes, it's the intent is real time. But the one thing I want to clarify, that's really on the hospital side, right? To get the notification outbound. If the subscribing provider says I want daily feeds, that's okay, or weekly. Like they can set their preferences for how they receive it. The expectation is on the hospital though to send that to ConnecTN, meeting the kind of CMS timeline requirement.
So last question so far, it may be addressed by kind of the next section of our presentation here, but they ask, so getting the alerts depends on whether or not the agency receiving the information is participating in the program. And I think, Samit, your presentation will talk through that type of a situation. Yeah. when a provider is not necessarily connected to our system, a way that we can still send that notification to them on your behalf. Is that correct?
That's right. Yep.
All right.
I can address
Let's jump
that.
right there.
Great. All right. Thanks, Brian. Thanks, David. So again, ConnecTN is operating this service now, delivering a ton of value in the state of Tennessee. There are important ways in which we will upgrade the service to support the rule. Two key ways. So the first is, as Corey mentioned, the rule specifies that a patient can now assert or tell the registrar or staff that they want a given provider, and that might be a PCP. It can be more than a PCP, a physician that's not their PCP. That physician be alerted. And there's a little bit of irony in this. We built this solution and have been operating it for coming up on a decade now. And some of the earliest systems actually relied on the patient saying who their PCP was. And as I'm sure all of you know, you can't really build a robust encounter or notification solution if this was the only way that you would rely on understanding who to alert. But we understand that CMS is, and really healthcare generally, is moving to a far more patient-centered approach. And so we see it as a good thing and important to begin to support as the rule specifies. And so as your registrar staff and your workflows get updated to explicitly ask patients this question, what ConnecTN will do is, with your existing feed, that provider's name that comes through the line with their NPI, ENS will read in, and we will alert that provider that their patient has now shown up at the hospital. And we'll do that in a couple of ways, and I'll get to this in a second. But while we're on this diagram here, if the provider is already subscribed, we will honor their existing preferences. Thank you, David. And send them out the way that they currently receive alerts. And this is an important thing. Back to the points David made, workflow matters, and we know it may not be the doc that wants the message, it's the staff that makes the phone call, and or other staff members in the practice or organization. If the provider is not subscribed, meaning they aren't maybe actively participating with ConnecTN and they don't send a panel of their patients to ConnecTN, then we will send the message via direct. Hopefully you all are familiar with the direct standard, which is secure email, supposedly made for healthcare. And there's a national directory of direct addresses. It's a little bit of a mouthful. And many providers, most providers in states are their direct addresses in this directory. Not all of them are. And it's one of the things that we think is going to change as the rule comes forward. And we expect that directory to become incredibly robust and really capture all the direct addresses out there. But we will be using that address directory to know where to send the message. And we'll send that on over to those providers that may not be active subscribers and active participants of ConnecTN. Maybe I'll stop there and field some questions. We do believe, so a couple more points to make. Well, folks have questions. We do think it will be in the best interests of providers who begin to receive these messages via direct to formally subscribe to the program because of all the benefits a formal subscription provide, like preference setting, where majority of providers just want to know when a patient's discharged, because that's when their staff can follow up and do those important activities. Some organizations may have the capacity and bandwidth to engage with hospitals during admission for discharge planning and that sort of thing, but not all. And so those preferences matter. And it's not only preferences of event type, but as David noted, preferences in the manner in which we deliver the alert. So it's not an unimportant point that we think formal subscription will really benefit your organizations and not just sending these messages out to direct. I think it's going to be interesting to see across the country as these doctors' inboxes start to fill up with these messages, how important services like ConnecTN will be. All right, next slide, David. The other key feature, if you will, that ConnecTN will support is developing a CMS audit report. It's not lost on us how important it is to be fully compliant and clearly compliant. So when that surveyor or auditor shows up at your doorstep and your compliance team comes and then they pull in other departments depending on what they need to demonstrate, IT gets involved. ConnecTN will provide a report to your teams that then you can provide to that CMS surveyor and auditor. And it will very clearly address each facet of the rule that Corey laid out. And so specifically, every one of those unique events, whether it's an ER registration event, an inpatient admission, an observation stay, an inpatient discharge, we will include, in the denominator, account for those events, and in the numerator, relay just how many of those events related in an alert. And then we're going to take the further step in saying just how we alerted those providers. Did we send them a direct message? Did we send it through some other route? And so it'll become clear for those, all the hospitals that are participating, that your organization is on board using ConnecTN and meeting every part of the rule. We will be adding other elements to this report over time. I think it's important to note that CMS has not given an incredible amount of guidance on just how this survey process will work. And Corey and our team are monitoring that activity closely. And as soon as we get more guidance, we'll update the report accordingly. And then the final point I'll make on this is if your teams, your compliance departments have a point of view, have a perspective that you feel we really need to address, certainly as you provide feedback to us either on this call or after through David and the team at THA with Brian, let us know. And this is going to be an evolutionary process, and happy to support you however you see fit. Maybe I can field one of these questions, Brian. Will it be mandatory for the office to follow up if they get a notification? Again, there is no requirement on the ambulatory practices or the recipients of the alert to do anything at this phase, at least. And so, no, nothing needs to be done. It's important to note that these systems, it's a pretty remarkable step that CMS would take to make this a condition of participation. I think it's a demonstration of how critical counter alerts and care coordination are to good care. So we'd certainly encourage it, and we have tools that enable your practices to do a good job and to do it easily, but no requirement, no mandate. Any other questions so far? All right, next slide, Devin. Final point to make here is we know, again, that compliance matters, and that's why most of you are on the call today. But the ConnecTN strategy goes far beyond having a solution that allows you to be compliant. We're doing important things like connecting skilled nursing facilities and their encounter data, because we know how critical it is for ACOs and practices and really all segments of healthcare to know when patients transition, whether it's from a hospital or a SNF. So the network growth of ConnecTN is an important way in which we're going to deliver novel value moving forward, and extends far beyond meeting the reg or the rule. And then the other piece to note is when these systems are deployed, I think people mentioned home health and hospice, and ConnecTN has been built to serve that vast array of healthcare providers and healthcare stakeholders, and does so today. And so whether it's the PCPs alone or specialists, home health, we're positioned to alert those organizations whether or not a patient explicitly states that they want their home health. I mean, they won't do that, right? They won't say, I want my home health provider notified, but we know how important it is for them to be notified. So again, supporting care coordination fully and robustly in Tennessee is important, and something we are continuing to strive for moving forward. And then the final point on beyond COP compliance, the rule doesn't actually mandate a lot of information be conveyed. It's, what hospital did that patient visit? Who was the attending physician of record? Which may not even be that valuable, frankly. And then the nature of the event, which of course, discharge and those kinds of things are pretty critical. But the ConnecTN service offers far more in the way of information that's valuable for care coordination. We include diagnoses and reasons for visit, discharge disposition. Do they go to a SNF? It's good to know where they go, right? If you're going to follow up. And so there's a long list of different data elements that we deliver via the alert that we've heard from you all is valuable over the years, and another reason why we're excited to continue to iterate on the service and provide value. All right, any more questions on the product and how we're supporting the rule, or really any questions at all?
I haven't seen any more come through.
Okay. All right, back to you, David.
Thanks, Amit. So you've heard from Samit and Corey and others kind of throughout this presentation so far that this rule is somewhat technical in nature, but there is also a variety of non-technical considerations that you as a hospital may require action. And so what we've done over the next two slides is kind of made a grid that breaks down key components of the COP, and then as we look at technical and non-technical areas in which our solution helps where your EHR system has responsibility, and then on the non-technical side, how we can support you and key considerations that you may need to update on the hospital side. So I'm gonna kind of walk through key components here over the next two slides. I won't cover all of these word for word. We will make these slides available, but wanted to highlight a few key points. So this first one, system is fully operational in accordance with all state and federal statutes and regulations. Security is of utmost important to us. I mentioned earlier that our solution is high trust certified. AI is audited by a third party every year. And then on the hospital sending side, this applies to EHRs or hospitals with compliant EHRs. In the middle tier here, notification events and settings, we have a detailed specification. Many of you who are already participating kind of know that this specifications document is kind of governed and managed by an ADT technical subcommittee at THA. And what we will be doing as a reflection of this rule is going to that committee and updating any key changes, one of which is observation, and having a kind of a detailed plan to go back to hospitals, each unique hospital, and having them update their feeds where they're not in compliance. On the EHR side, that would just require going back and updating your existing feed. Again, right now it's all payer data that comes in, even though we're meeting the 10-care ADT requirement for hospitals. We do get all payer data from participating hospitals today. And then notification timing, again, our system operates in real time where ADTs come in to us in real time. The matching to subscriber panels and the generation of alerts, all of that happens in real time, and we send those out today. So the next slide is kind of layers in the non-technical considerations, and we've flagged here, again, key components of the rule that will require changes to existing policies, procedures, or registration workflows so that you can demonstrate to an auditor how your organization will comply. So one of these, for example, is notification content and notification recipients. So many of you may have established workflows, for example, at registration where you're capturing the patient's PCP, but many of you may not be capturing post-acute providers or other patient-asserted providers today, and that will be a key consideration as you update those registration policies and procedures. So kind of over on the right here, these are considerations on the hospital side, and then we will be providing guidance as it relates to all of these non-technical aspects through collateral for you. We'll be providing kind of a hospital checklist of things to consider. I talked about the technical side of this that requires kind of a data quality analysis of the existing feed and modifications to that. But then also on the non-technical side, key considerations and policies to consider. And then our team will continue to be a resource kind of as we march towards this May 2021 date when this rule goes into effect. I'll let folks kind of catch up here before we get into kind of next steps and how you get started. So we will continue to take questions, but feel free to send those in. So we've separated how do I get started here really into two buckets. One is acknowledging that many of you are already participating in this program today, and kind of your takeaway from this call of what you need to do. There's no immediate action on your part. We are in the process of doing a very detailed data quality analysis of every inbound feed to us. We're also in the process of flagging any changes that need to happen to our ADT specifications. Those will go to the various THA governance committees for consideration. And then what we will be doing over the next 2 months is following up with each individual participating hospital with any changes that need to take place and kind of the results of our detailed analysis with any gaps that were identified. And then also on the hospital side is if you have specific providers or organizations that you would like to subscribe to this service, please flag those for us and we can get those folks onboarded ASAP. On the right side, if you're not currently participating, we have an email, ConnecTN@tha.com that goes to Brian and me, and we will get this process started. And there's essentially a kickoff call, there's a participation agreement. So if for members of THA, you're participating in the claims data program. There's a one-page addendum to that as it relates to the ConnecTN ADT program. And then we proceed with technical work of just establishing VPN and building that interface. And then we will manage the COP compliance for you. I saw there were a couple of questions that came in. I'm going to go ahead and read those. One I see, can you give an average amount of time it takes to enter event information? So I think I'll take this from an ADT standpoint. Most EHR systems, the ADT interface that comes outbound is kind of the backbone, and every workflow event that happens in the EHR kind of triggers a distinct event. So it's not really a manual process. I think maybe this question is from a behavioral health facility that may not have a compliant EHR, and there are several psych hospitals today that are sending us files instead of actual real-time feeds that we then convert. And those of you who are doing that today, we will be reaching back out to you with kind of results and guidance of how to change that process. I don't know if that was the question that was answered though, or that was asked. So I'll invite you to clarify or let others chime in if they have anything else to add to that. Second question was, is there a charge for the use of this service? There's not a charge. I'll cover that on the next slide, but we are essentially going to, for existing participants and new participants, we're going to meet this COP compliance for you at no additional cost. There is a time component of if it's a new connection, building a new interface fee, but there's no actual fee that will be passed on to the hospitals.
And David, one bit of clarification there. And as we've discussed, we have 120 hospitals connected today. For THA members that participate in our data programs, there are no additional costs. If you're not a member of THA, there are some very minor, I would say, connectivity costs, and then there's a yearly fee. Again, we kept that as low as possible just to encourage participation. But so for non-member hospitals, there is a slight fee. But if you're a member of THA, if your organization is a member of THA, there are no additional fees for this. And as David mentioned, this specific COP, not guidance, but the work we're doing to help you meet these requirements, there's no additional costs or anything like that for that. So,
thanks, Brad. Another question that came in from Kim: how are most hospitals providing continuity of care documents to other facilities, PCPs, and SNFs? Are they giving those providers access to their hospital system? We are not currently receiving CCD documents, CCDs or other clinical information. We're just getting ADT feeds. So there's many of you may be familiar, there's a series of national networks where those types of clinical documents are made available through participating EHR systems. That's one way. We are not currently offering that connectivity through ConnecTN today. It may be something that we do at a later time. Bobby, great question. Please define ADT. ADT stands for admission, discharge, and transfer. Any other questions? All right, we still have a little bit of time. I'm going to move over to a summary slide here. So I know we've thrown a lot of information at you today. Some of you may be familiar with this rule. Some of you may be hearing about this for the first time. And just a couple key takeaways is, most importantly, we want you to understand that your participation with ConnecTN will enable your organization to comply. We will, our policy and software expertise and experience in this space we will make sure that we hold your hand every step of the way and provide you the tools and the guidance necessary to comply. As Brian mentioned, for THA member hospitals, there's no additional cost or fee for COP compliance. And then for non-member hospitals who wish to participate in this program, there are small fees that we can outline for you if you're interested. Today we are helping all of our connected hospitals meet the 10-care state ADT requirement. This is now an evolution of this program to also meet the new federal requirements of COP through the CMS interoperability rule. AI, as Samit mentioned, our encounter notification service was developed 10 years ago and operates across the country with 20% of the nation's beds. And in the state of Tennessee, we have 80% of beds connected. And notifications, encounter notifications is what we do. And we would love to play the role as an intermediary for you in our partnership with THA, all under and governed through the appropriate data uses at the association. And really our goal for existing participants of this program is to evaluate your current feeds, identify any gaps, and just make sure that we are covering you 100% as we approach this May 2021 deadline. So we will make these slides available, and we will, this webinar was recorded, so we will also send that out. But Brian and I will be available after this call. You can reach us through those questions and or through that contact email, I should say, ConnecTN@tha.com. But Brian, I'll turn this back to you for kind of ending Q&A and then closing remarks.
Thanks, David. We did have a couple more questions come in as you were talking there at the end. Shane asks, does this address the CMS rule? And so, sorry, this is you, Corey, more than likely. Yeah. Does this address the CMS rule for patient access API and provider directory API policies for Medicare Advantage, Medicaid, and the CHIP program?
No, it does not. That's a completely separate requirement with a different set of conditions and things you have to do. It's not related to the ADT notification requirement.
Yeah. And then the next question, from an HL7 perspective, you do not do scheduling messages either or pharmacy. Is that correct? So David, do you want to cover that?
Yes, we do not get pharmacy messages. That's a separate feed type. The scheduling messages, I think it honestly depends on the originating system. So sometimes a registration or scheduling system will send an ADT feed. Sometimes it's the EHR system. I don't know if Brandy, if that answered your question though.
Yeah. So that's it. She said, thank you. So that's it for the questions that I have. Certainly appreciate everybody's time today, and hopefully you got some guidance and better understanding of this specific requirement and how ConnecTN can help you meet that requirement. As David mentioned, he and I are available if you have any specific questions. Big picture, next steps, if your hospital is already connected with us, we will be analyzing the feed of information that you're sending to us, as David mentioned, and looking to make sure we have all of the data elements that we need to carry out this new service and get you compliant. And so we will be following up with each of your hospitals with more information. And if your hospital is not connected with us today, also please reach out and we can get started on that and again, get you to a place where you're compliant with this COP. And again, if you have further questions, ConnecTN@tha.com, and we'll get back to you just as quickly as we can. We will follow up after this with a copy of the slides and a recording of the webinar if you would need to share it with anybody internally. But again, thank you all for your time. Thanks to AI for pulling this together. And we'll look forward to talking to you all soon. Thank you.
Thanks, everyone.